Next, according to the program, we will now listen to Dr. Alfredo Sierra Unzueta, who is already with us this morning. He's from the Angeles Lomas Hospital, working in intensive care. He's going to talk about effective circulating volume in trauma. Dr. Sierra. Good afternoon, everyone. This is a very interesting topic, and if you begin by asking yourself, what is the effective optimal circulating volume? I think I won't be able to finish answering this afternoon, but I can offer some ideas, and I always like to refer to physiology and also to the changes that illness brings about and the physiopathological aspects that we see. What we most see in trauma is shock, hypovolemic shock, even though you can also see other issues come up. But as I was saying, if you think that optimal effective circulating volume is that which allows us to have ideal flow to right and left arteries, veins that will allow us to have the best heart blood flow, the best blood pressure, the best perfusion, the best contribution or flow of oxygen to tissue, then I think that we could say that it is basically an indirect way of saying that the circulating volume that we achieve this way is the effective volume. So what do we do to achieve this effective circulating volume? It generally refers to the volume supply, and we generally refer or use blood or blood products or crystalloids, as was mentioned this morning, or hypertonic solutions like sodium hypochlorite, and we're always trying to find something that will remain in the interstitial spaces so that we can achieve the effect that we desire on the physiology of the circulatory system with the heart as the pump and not damage the lungs or other vital organs. But if we talk a little bit about the tissue oxygen debt, we realize in this experimental study, which was very well done, that when we have a person in a state of shock, we start to have oxygen debt. And that if we reestablish the circulating volume correctly and we have good blood flow, and we stabilize the patient, we have a phenomenon which is seen in green and going upwards where we pay this tissue oxygen debt that we had when in shock. And if we pay this debt correctly and sufficiently, in this experimental study, animals were able to survive. But if the oxygen debt is not corrected in any manner, then the evolution is fatal, or the devolution, and all of the animals died. But also, when in intensive therapy, we have patients where resuscitation was late or it was not done correctly before reaching the OR, or if they were in a prolonged state of shock that was not treated correctly, then generally this oxygen debt is prolonged too much time, and when you try to pay it within the intensive therapy, you're no longer able to do so. You cannot pay it adequately when the patient was very seriously ill for a prolonged amount of time before reaching ICU. So we start having vital organ failure, and in sequence, one or the other begins to fail until the patient has a very poor prognosis. And this definitely affects mortality. And the other problem that we studied quite a bit at our unit was to see how or what happened to patients that got over severe septic shock. And we compared the patients that were in this condition. We measured the severity through Apache, but we realized that most of the patients that we lost were patients that had had an accumulated balance of fluids in a very important manner during intensive therapy. So these were indicators of a poor prognosis, having a high Apache. But if day after day you have a positive balance of liquids or fluids, and the greater that balance, the worse the survival prognosis was. And this coincides a lot with the presentations I heard this morning as to the concern that exists in trauma care when you fill patients up with fluids. And I can assure you that 10 or 15 years ago, I started talking to people at the shock trauma unit that dealt with patients that were severely injured. They weren't worried that much about the volume. They said, yes, the patient is going to swell up, but that liquid, that fluid doesn't matter. The patient will recover later on. What's important is that we have correct tissue perfusion. And if he gets too swollen, we'll have renal therapy with a prism, continuous therapy, and withdraw the fluid, and the problem will be solved. But apparently, that's not the way things are. And why is that this slide is a little bit complex, and I don't have a pointer to be able to explain it to you, but I want you to see that the numbers that are above the 7 and the -2, these correspond to normal values of hydrostatic pressure, microvascular pressure, 7 in the microvascular space, intra, and -2 extra. And what we can see under the 25 and 16 numbers are oncotic values, intravascular 25 and extravascular or paramicrovascular of 16. And the numbers, which are very important, are the numbers that we see there as 0.7. This is the reflection to proteins coefficient. This shows stability, showed in a very graphic manner. And so that you can see that the number 3 under normal conditions is the result of the pressures that are trying to get rid of fluids or liquid, and those that are trying to stop the leaking of liquid, the oncotic hydrostatic sequence. And 20 is the filtration coefficient, and we're here referring to the lungs. So if 3 is the result of these forces and 20 is the coefficient, we have 60 milliliters that are going into the lung interstitial spaces, and this liquid is regulated by the lymph without any problems in the lungs. And when we talk about resuscitation and using crystalloids and other solutions, we have to think about how these forces can be affected in the patient during resuscitation. The first thing is that the oncotic pressure has to be reduced because all of the liquids are going to be diluted, and the oncotic forces are going to go down to the intravascular space, but also the interstitial space. And the sequence of data in our information is that the flow of liquid to the interstitial spaces is going to increase from 60 to 100. And this is in conditions of hemodilution or dilution of the proteins. But what happens if, in addition to this, we have a systemic inflammatory process because of sepsis or severe trauma? The coefficient, which used to be 0.7, is going to drop to 0.5. What does that mean? That more proteins are escaping more easily to the interstitial compartment, and the resulting forces will have a lot more liquid with proteins going into the interstitial space, and the lymph can't drain it, and the interstitial compartment starts to accumulate liquid. So if we have the permeability affected and the proteins have been diluted, this is the result that we have: a swollen patient, different parts of the body and the vital organs, and also in the lungs, which is a super important factor for what we do. And we arrive at very serious situations such as this, where we have an impressive amount of volume escaping that cannot be drained from the lungs, and having the patient with lung edema plate is very frequent in ICUs after resuscitation. And I think that our road from this point on will have to be that we resuscitate without so much liquid, but use a 1-to-1 proportion of blood, and also to use methods that guide the use of volumes in a judicious manner, and that we try to do as much as possible for them to remain in the intravascular space or compartment and have optimum circulating volume. Studies have been done as to how in experimental conditions we affect permeability, proteins, and the filtration coefficient, especially because of the polysaccharids, bacteria that are capable of affecting permeability, and this complicates even more management situations for us to be able to achieve effective circulating volume. You all know well ATLS and the guide that they provide based on the amount of volume that has been lost. So I'm showing 4 slides just to talk about the 4 levels at which ATLS graduates, the loss of volume, and the clinical manifestations. And it's stage 1, stage 2, where we can also use crystalloids, they recommend. And when blood loss has been greater, then we start to need to use blood. And the more serious the situation, well, more blood should be used in a patient that has suffered trauma. This has been a very good guide because it helps us in a practical manner and in a very clinical manner without having to measure anything. We are able to basically estimate what biological product and when we need to use it. And there are also flow diagrams that allow us to do better follow-up based on the heart's function, establish therapeutic goals, determine how much volume, how and what quality of volume. And then we reach intensive therapy, and we start to see that when we used to measure central venous pressure or the pressure of the right vesicle, it's not enough for us to be able to determine whether a patient requires volume or not. We started to use the delta of the systolic pressure peak and also the systolic pressure delta, and in order to evaluate which of them was the best. But it turns out that the measurements of the variations in blood pulse pressure in sedated patients is a good indicator as to who is going to be able to respond to volume and who won't. But not all patients are in this clinical condition, sedated, relaxed, receiving controlled ventilation. And also, there are many factors that can influence this because BP is going to change when the respirator first provides its tidal volume, and if it's 6, it's going to have a certain effect, and if it's 8 per kilogram of weight, it's going to be different. And generally, the patients that are going to respond are those that have important variations in their pressure and pressure peaks, and it's this way because we can see this in the Frank Starling curve. In the responders zone, which is when we increase the preload to the left ventricular, then it increases because they're in this part of the curve of the historic pressure. But those that are in the flat stage, which are the patients that won't respond to volume, are the ones that probably already have excessive volume and poor cardiac function, and therefore the volume provided to them is going to damage them because they're on the flat part of the systolic function curve. And all of this, as to responders and non-responders and the movement of the pulse curve, etc., all of these things help us in certain clinical situations to be able to determine who will respond and who won't respond. But we also have another series of issues, the most frequent in intensive therapy, which is that patients are not sedated, relaxed, and stabilized. We have many other issues to deal with. And in patients that are not in perfect conditions, we don't know how much and what volume. So we start to have these failures insofar as the variation of the heart rate pressure. So the problem is even more complicated. Here we have 2 common volume situations, one with 8, the other one with 6. And we already see differences in the interpretation as to who can respond and who won't, and when the curve can be good and not so good. And it turns out that here with 8 millimeters of tidal volume per kilogram of weight, the results will be better than when you have 6. So all of this is because of the interaction between the heart and the lungs functions. These are very dynamic situations in a seriously injured patient. So what we do day to day in intensive therapy is full of different factors that prevent us from being able to assure optimum circulating volume. And that's why I said before that it's complex and difficult, and that there are many things that aren't working right. But apparently the delta of the peak pressure is an acceptable and good variable. But we can also raise the legs so that we can do a volume test in this position without providing volume. In patients that are not receiving mechanical ventilation, or even if they are, but they're not sedated. And in this manner, we can perform a test that allows us to determine if they will respond well, if the cardiac flow will increase when the legs are raised. It's that the preload increased because the heart pumped, and it's a good indication that the patient will respond to volume. I reviewed the studies that exist as to raising the legs, and I found a very good meta-analysis which reviewed almost all of the studies that had been published previously as to raising the legs, and they do indeed consider it, as you can see here, to be favorable, that this test of raising the patient's legs in different studies that were done by different investigators at intensive care units, that it's a very good test to be able to determine whether the patient will respond to volume or not. But there are other things that we have to talk about in order to ensure the volume. One of these is the continent that we can modify with vasoconstrictors, and the other issue is the volume itself. So apparently in a patient with serious trauma, vasomotion is also affected, and we may have regional vasodilation that can sometimes make us use vasosuppressors, such as the use of arginine vasopressin, which apparently is better than using norepinephrine or epinephrine or other agents because it's a natural vasopressor or pressin with a much better effect, and it doesn't degrade with changes in the pH or anything, which is what happens with catecholamines. And another study that I thought was very interesting in this review that I did for this conference is that I found a study that was done by a group of people, military, space medicine. What they're doing is evaluating a new system and creating algorithms to be able to define the use of volume in people with serious trauma, especially in war situations. And there's something that interested me tremendously because they use as a basis variations in pulse pressure, and obviously that with the value of systemic pressure, they don't assign any value to systemic pressure, and they don't assign it any value because of what you can see here. With this infrared photoplethysmography system, you can see that in the upper part, it shows a very normal pressure curve, a very good one, 130 to 70, at a reasonable with reasonable frequency, and the lower part using the same system, we have 110 with a diastolic pressure of almost 70. But the changes in the pulse pressure morphology are what they assign the greater value to in their interpretation. And why is that the case? Because in a live organism with an intact neural response, what makes it respond through vasomotion mediated by the central nervous system to try to have the arterial pressure not drop. And it does achieve it. As you can see in the upper part, there are no changes in the pressure curve when the circulating volume hasn't dropped. But in a simulation of circulating volume loss through negative pressure of the lower part of the body, which is what brings about hypovolemia, almost as if it were real, and when you take it to different magnitudes, you can see that the numbers for arterial pressure continue to be on the bottom part, 116 and 78. Arterial pressure continues to be the same, but what is changing is how it moves or how it's moving, and it is especially an extraordinary mechanism of adaptation, neurally mediated. So the study tells us that it's possible to simulate severe hypolemia using pressure in the lower part of the body and to measure the response of the body, but that we have to be very careful with the neural response. The nervous system very quickly tries to produce vasoconstriction to correct the problem that caused it. So here we have two different situations, one achieved by true hemorrhaging in a patient in an intensive care unit. His arterial pressure is dropping and because of hemorrhaging after 50 minutes, and the other one where we have negative pressure in the lower body, and when it reaches minus 70, pressure falls rapidly, just as if it had had that blood loss. So it is possible to simulate through these studies what we sometimes see. And you can see the neural response here when the intravascular volume drops, whether due to blood loss or because it was simulated in this extraordinary system. What is affected, especially the vasomotor neural response, which is going to make the pressure curve and its morphology change. And through a series of algorithms, computerized algorithms, we will be able to determine how much blood is required by the patient. I hope that this is going to result for us. I don't want to end my presentation. You can see here that the neural response is much more important. Neural response vis-a-vis volume changes. You can see the lower part, the effects of the nervous system on the vascular system that is trying to produce vasoconstriction when there's a simulated hemorrhaging. But as I said before, I want to mention two things that I believe presently are extraordinary weapons. One of them is obviously what's happening to the inferior vena cava, as was mentioned this morning, and it can be measured in different ways. The most dynamic and the fastest way would be to do it with echo, but as a matter of fact, there are situations in which even if we have wonderful echo to be able to decide whether we give it volume or not, in serious trauma and in patients in intensive care, we can use methods such as measuring it through scanners that look at the diameter of the inferior vena cava. This method, the dark blue, shows the flattening of the vena cava, and it estimates that it's the best indicator as to whether the patient will respond to volume or not. And as I was saying before, ultrasonography or ultrasound, that we see the movement of the inferior vena cava, the heart's contraction, the heart that is beating poorly and has contractility defects, the differences between the left and the right side insofar as contractility. All of these differences are creating a new medicine for us presently that has changed the way that we see and that we interpret what is going on in our seriously ill patients insofar as their volume. But my the last thought that I want to share with you is to tell you that the road before us is to use less volume. It's to be much more judicious with the quality of the fluids that we use, and I'm not referring to albumin that degrades and suppresses cardiac function and affects renal function, and it's very good to maintain cardiovascular pressure, but it has very deleterious secondary effects. But I'm referring to hypertonic saline solutions that remain very well in interstitial spaces. They allow us to lose less volume and to have a better effective circulating volume and have a patient that isn't as swollen. But also when there is no other option, to give the patient volume for his resuscitation, but to quickly use renal support systems to be able to reduce the swelling as soon as possible. Thank you very much. Thank you very much to Dr. Sierra. ¿Alguna pregunta en el público para el Dr. Sierra? Yo tengo una pregunta, muchas gracias. Tratando de medir la presión para el volumen, eso ya no. Ahora, si vemos el volumen con el ultrasonido, eso es algo que ahora hemos aceptado.
Modalities that are there, if you came across those or any experience with them in the trauma population, like monitoring the arterial line with the stroke volume variation, does that play any role, do you think?
El stroke value ¿cree que tiene algún futuro? Yes, that's a very good question. the pulse pressure and continuous measurement measured directly. It's a very good variable that we should follow for a patient that has suffered trauma. We do it routinely at our ICU, but the farther you go from measuring aortic pressure and the major vessels, and you measure it in peripheral arteries, there starts to be a variation or a change as to the reality that's happening in the central part. Long ago, I learned that measuring pressure, peripheral pressure, isn't as good as having a measurement at the central area with a catheter that measures close to the aorta or the underarm closer to the aorta. But we're not doing that presently. But looking variations in the pulse is a good indicator, much better than the value in numbers of arterial pressure, which I think we're assigning less and less value every day. Muchas gracias. Thank you very much to Dr. Sierra for his presentation.